Today's episode is sponsored by Vitality Health RX Supplements. Whether you're an athlete, a busy professional, or just someone looking to prioritize health, Vitality Health RX has what you need. With premium ingredients and rigorous quality control, their supplements support your body's natural functions. Visit shopvrx.com and use code FEELGREAT15 for 15% off your first order. Thanks to Vitality Health RX for sponsoring this episode. Now let's dive in.
Welcome to the Feel Better, Feel Great podcast, episode 125. I am Dr. Andrea McSwain. As we delve into the podcast, I want to remind you that while I am a medical professional, the information shared here is intended for education purposes only. It is not a substitute for medical advice. Please consult with your healthcare provider for guidance on your specific healthcare needs. Let's get started. Today, I want to talk about the various aspects of bladder health, incorporating both conventional and holistic approaches to the diagnosis and treatment. This is definitely geared towards women's health, and the primary diagnosis that I'm going to talk about is urinary leakage or incontinence. Okay, here's a few key points that I have come to find in my clinical practice that I feel are really important. Okay, first of all, the bladder cells have a 200-day lifespan. When that might not mean anything to you, but I want you to compare that to the gut, which has a 23-day lifespan. So the cells in the gut turn over about every 23 days. And that means a lot of times when people do a gut protocol, they feel better really well. Really quickly. And I like to do my gut protocols, and I like to have 3 turnover cycles so that I get a lot of nutrition and healing support with the gut 3 times. Now, when I look at the bladder and the bladder health, I really would love to have 3 times that I can get cellular turnover. That is 600 days. So we're looking at the better part of 2 years. My argument there is, what else are you going to be doing? Because if you have a bladder problem, it's really important to focus on it, but it does require quite a bit more maintenance and kind of commitment to the long term. But I think it's worth it because you can look at cellular turnover and kind of understand how long it's going to take for these bladder cells to repair and then start having just normal replication, which means symptoms will reduce over time as the cells are healing and the tissue is rejuvenating. Another important consideration for the bladder, it might seem obvious, but the bladder is the final stop for waste elimination. And therefore, it can experience a lot of irritation and difficulty in function because it has constant activity. Okay, so when you think about the bladder, it really is a sac with one muscle that's in the back, that's in the shape of a triangle, where the base is the top of the triangle. And that muscle is called the detrusor muscle. In a bladder, you have 2 tubes coming from the kidneys. You have a bladder sac, a bladder muscle, and a tube leaving the bladder called the urethra. And for females, the urethra is only about as long as this first joint of your finger, pinky finger, whatever, approximately. So you're really looking at a very short tube before you get into the bladder. When you also think about the bladder as a sac, that sac has to be squeezed by that one muscle. Now, that muscle receives nerve stimulation, but that muscle has to squeeze and release in order to help the urine be evacuated. And that is basically the crux of that organ structure. Then we get into the diagnosis for the bladder. My main emphasis, like I said today, is urinary leakage or incontinence. The reason that this is paramount for discussion is that the majority of nursing home admissions are due to bladder and bowel incontinence. And while bladder incontinence is much more tolerated than bowel incontinence, I think it's still a significant issue that really impairs someone from being able to stay in their home and maintain their own independence. And it's very, very taxing on caregivers. So let's work to make a better tomorrow and look at how what you do today can help you reduce urinary leakage, overactive bladder, and then incontinence. So maybe your goal is to stay in your home, or maybe your goal is to never have any family member wipe your butt. And so that's what I have to say. Maybe a little graphic, I apologize. But definitely when we look at quality of life metrics, I think that's a pretty significant one for people. All right, so looking at overactive bladder as kind of a starting point, because this is kind of the beginning of the problems, right? The bladder is irritated easily. You might get up at night to urinate. You might have to always know where the closest bathroom is. Some people know every gas station from point A to B that has a bathroom that they like to go to or they find acceptable. And so I don't want you to have to characterize the gas stations from where you live to some other place that you go that's a short distance. So anyway, that is kind of how I view overactive bladder. The bladder is becoming overactive is because irritated. Okay, and I'm going to get into some other issues there. Then we get into a whole kind of subtype for incontinence, and I will tell you, basically, one of those structures is having a problem. Oftentimes, too, there are reasons or triggers that have led to urinary issues. So oftentimes, for women, that is weakened pelvic floor muscles or sphincters, which are the valves. So sphincter is a valve. That's related to childbirth, trauma. It's related to trauma other than childbirth, like landing hard on a bicycle seat as a kid or horseback riding sometimes, tailbone injuries, motor vehicle accidents. In menopause and aging, there can be some hormonal changes that come into play that also exacerbate incontinence. And then there's triggers, right? That coughing, sneezing, laughing, jumping, lifting heavy objects, all those things create pressure and kind of override the pressure valve system in the bladder. And so there ends up being urinary leakage. So I hope this is helping you understand those things. There are other times where people get the urge to have an intense flow or leakage, and that can be related to muscle spasm, which is really important. And then there are, of course, neurological disorders. There are certain medications and even nutrients and foods that can irritate the bladder and the bladder muscle. When you think about the bladder muscle spasming, the bladder muscle is irritated, and that is why it is spasming. So oftentimes that can be related to infection. It can also be related to nerve irritation related to sacral or structural issues. And there's some other terms for incontinence like mixed, overflow, functional, you can't get to the bathroom in time due to arthritis, mobility limitations. Obviously, there's other things like longer down the road, like dementia, cognitive impairment. And so I want you to understand kind of those different types. I would say by and large, they might be important for some specificity for different diagnosis codes, but I really feel like there's a lot of ways to treat the bladder regardless of what subtype of incontinence is. The other thing is I think a lot of times people get that diagnose and adios situation. So they find out what subtype of incontinence they have, and then they're told to go home and use a pad or a diaper. And so I don't really feel like always going down that rabbit hole of knowing the subtype is as important as actually knowing how to address it and things to avoid in how you address it. Okay, so first of all, when you look at incontinence, you have to look at structural issues. We're going to get to that in a few minutes, but also urinary tract infections. And not just the ones that are found on urine analysis, but also the ones that you just know your bladder is being irritated. So there's subclinical urinary tract infections or harboring of bacteria and fungus and Lyme and mold. Anything can sit in that sac, which is basically a breeding ground for the overgrowth to happen there, especially if the bladder is not emptying all the way. And so the muscle's not squeezing all the way, or the muscle's squeezing, but it's spasming, and so it's not releasing all the urine. So think about that. You have that bladder sac, and it's pooled with urine, and it really can harbor any overgrowth of anything in it. And so when we look at incontinence, make sure that you're looking at issues of urinary tract infection. Also, persistent urinary tract infection wreaks havoc as chronic inflammation on the bladder. So recurrent urinary tract infections are often like just viewed as recurrent acute urinary tract infections, but actually, when does it become chronic? When I think it persists over 6 months, whether it's sporadic / intermittent, or if it's constant. So if you're getting a lot of urinary tract infections and they're recurrent, please do not look at them as individual episodes, but actually as a persistent irritant in the bladder that really does need attention from an idea that this has become chronic. And so there's some different considerations as to how long it's going to take to recover, but it's very possible to recover. When you look at a urinary tract infection, a lot of times, as I said, people look at urine analysis. This is called a UA. Sometimes the urine is cultured, so actually identifying what pathogen. Now, this is almost exclusively looking at bacterial pathogens. And primarily, this is going to be an E. coli overgrowth that has gone into the bladder. There are many other different bacteria that can grow in excess in the urine, but you want a culture, and that isn't enough. You also need a sensitivity. So it's called a UACNS. And the sensitivity part is actually putting little discs of antibiotics into the petri dish to see what sensitivity there is to killing the bacteria. Okay, now if it's just looking at bacteria, you have to recognize that the bladder can harbor any number of other pathogens. That's important because if the urinary tract is constantly having infections, it can lead to more chronic conditions like overactive bladder and incontinence. Another issue I'm just going to highlight briefly, and I'll really appreciate the opportunity to talk more about it in the future, is something called interstitial cystitis. So cystitis is, cyst is bladder, itis is inflammation. Well, cyst is really pocket, but interstitial cystitis. And this has a lot of chronic pelvic pain. It's awful. There's food sensitivities. Of course, there's pain during intercourse. It's also called painful bladder syndrome. And I think that's a lot nicer way to recognize what the person's actually going through, because interstitial cystitis just doesn't sound very human words. So when I look at IC, first of all, a lot of times there's an emotional stress component, and that's a persistent irritant to the bladder, and then that can be what contributes to incontinence. Okay, going into now some diagnostics, so testing, labs, etc. The first thing is a bladder diary. Noting when you have, oftentimes people talk about bad days. I actually like to look at the pearls of when you have good days. I rarely ask someone to do a diary. I actually ask them to put smiley faces and gold stars on the good days, because when did it work, right? Diaries are often about when it didn't work. And I don't think the brain really wants to fixate on when it didn't work, because that's a problem that just gets harder. But if you work with your brain to figure out when it gets better, then I think that's actually a lot easier way to find success. So something to consider with diaries. Then a little bit on urodynamic testing. So introducing fluid and measuring pressure gradients for bladder stretching and bladder stress. Those have come out of favor quite a bit, quite honestly, because insurance payments have gone down substantially. So in the mid 2000s, they were like a hot deal, and they were really, really well reimbursed. Once they stopped being reimbursed so well, they stopped being recommended. And basically, you put your bladder under stress clinically by filling it with fluid, and then see how much you can handle. I don't know that there's really that much benefit to those, and they can be extremely uncomfortable. especially if you already have bladder pain and now it's being stretched. So I don't get it. And I think that some of the things I like to see instead, ultrasound. So ultrasound are very important to understand what's going on in the bladder. Most of the time, an ultrasound is going to come back fine on the report. And this is why it's critical to work with someone who actually reads their own images, because the ultrasound of a bladder can be extremely telling for how abnormal things are. If the bladder wall is white and thick on imaging, it is basically red hot, inflamed, thickened, and constantly aggravated. If there is the schmutz of the line, and so the line is not clear, that means there's growth happening on the bladder wall, which could be significantly contributing to bladder spasms and incontinence. Then, of course, there is something called cystoscopy. This is a camera with a long tube that goes inside the bladder. It's done usually under some kind of anesthesia. It can be done in the office, but usually under anesthesia. And so then you get a visual inspection. I think the ultrasound does a lot if you're actually looking at the images. And then, of course, exam. So what does the opening of the urethra? So the urethra comes out, or does it go in and direct towards the vaginal canal? Is it dilated, or is there scarring around it? Is the tissue around it white, showing scarring, or pink and thin, showing a lot of irritation in the tissue from constant exposure to urine? And then, so what on visual exam is happening to the area around the urethra? Okay, so going into some ideas that are conventional approaches to incontinence. First of all, behavior therapy, because as I say, we learn to potty train, and we do that. And so this is kind of what I call adult potty training, where, first of all, a lot of times people get up in the night, which becomes a habit, not a necessity. And then the body programs itself to wake up at that time. It is very important to recognize if you do need to go to the bathroom, or if you're awake, and so I'll just get up and go to the bathroom because I'm awake. Okay, but that sets in, so avoid that. That's also for men. That's really important, because that's one thing. The other thing is timed voids. So if you're finding your bladder's irritated, make sure to empty it as best you can every 90 minutes, and that's important. Of course, keeping things that are irritating, like caffeine, alcohol. There's definitely a lot of acidic foods that can contribute to bladder irritation. There's sometimes the good and the bad with that, but the caffeine, the alcohol really don't support your bladder, obviously. And the other thing is keeping any fluid about 90 minutes away from bedtime. So stop drinking about 90 minutes before bedtime. If you need a little sip, obviously, if there's a supplement or a medication or something, I'm not suggesting that you don't do those. I'm just suggesting that you have very little fluid intake before you go to bed by 90 minutes. Okay. Kegel exercises are often so people are told, go do Kegels. Well, I think he's a Dr. Kegel. Anyway, this person had a very good idea, but it isn't the end all be all, and it's a very outdated concept, which is basically squeeze your pelvic floor. Okay, well, if you squeeze your pelvic floor and then you try to create a pressure gradient against it, you might actually be further exacerbating the problem. So tightening the muscles and then trying to push fluid out through your bladder, that's a Kegel. And the other argument I have with a Kegel, besides the fact that you're modifying your pressure gradients, which is a bad idea with the body, the second thing is that you are contracting maybe in a Kegel, but what are you doing to expand? So muscles do two things. They tighten and they release. And sometimes there's imbalances in the pelvic floor. And so if the emphasis is only to tighten, then we're looking at actually some vessel constriction, and we're looking at creating something that becomes just very, very tight instead of pliable and adaptable. Then also conventionally is a lot of conversations about medications. So there are something called anticholinergics, beta-3 adrenergic agonists. So in a nutshell, what these do is that they alter the central nervous system they alter the peripheral nervous system. So they tell the bladder to relax. Okay, the problem is they also tell a lot of other things to happen through the body because the receptors, like anticholinergics and adrenergics, are receptors all over the body. And so a lot of times people want to help their bladder, but not at the expense of having dry eyes, of having dry mouth, of having a lot of other things not function correctly because this medication is modifying symptoms and creating symptoms in other systems because of how broad range of these medications are to impacting the entire body. So I've never been a fan. I've not seen people stay on them for very long. Usually they're aggravated so much by the other symptoms and they still have the problem with their bladder. There is definitely a conversation about topical estrogen to the vaginal tissue. Now, as many of you know, that's very important if you have the right estrogen, and because estrogen definitely helps tissue recover. But that has to be done with a doctor that understands estrogen support and how to actually get you the right topical estrogen. Okay, and then another road to hoe with this is minimally invasive procedures, and I'm going to put pessaries in this idea. So a pessary holds up the vagina. It goes in the vagina. It's a hard piece of plastic, and when it goes up, it kind of straightens the tubes, and then you have the bladder sac not so saggy, and then the muscle of the bladder can squeeze harder, and it will help the pressure. It will also help reduce the fluid retention, and the thinking there is that it will help you have things lined up better. Now, a pessary is a hard plastic. It doesn't fit well. It is possible it can cause problems in the vagina, like some tissue erosion, infection, very difficult to remove if it's stuck in that respect from infection and inflammation. And like I said, does not fit well. I've seen very few people be able to actually get this placed appropriately. I think it's still in favor in the conventional gynecologic community. I actually prefer other options that are temporary pessaries that can really support the body. And I'll talk about those a little bit later. If you're interested, DM in wherever you leave comments. So YouTube or Instagram, me at Dr. McSwain. Okay, some other things people use are bulking agents, which are synthetic around the urethra to kind of tighten it up or bulk it. They're synthetic. It's more aggravating. It's not a good idea. Or Botox, which is a nerve toxin, and it relaxes the bladder from spasming, but it is a toxin to the nerves and it's accumulating in the tissue. Botox is not benign by any stretch of the imagination. Of course, some of my other concerns about how to treat the bladder is so some surgical options. Basically slings. It's like kind of a hammock for the bladder. It's a piece of mesh. It is inserted in the OR and it goes through kind of an opening on the left side, and then you pull it through to the right side, and then you pull it out and you clip it and you close those holes that you made. And it you can kind of in the OR kind of move this sling. It's only about maybe 2 centimeters, so just shy of an inch. It's a synthetic mesh. And so what you kind of do in the OR is kind of approximate where the bladder should be. Now this person's under anesthesia and they're laying flat. And you're like, okay, like see how taut I need to make this or how relaxed. And then you tack it and then you close up those holes that you made, those little slits that you've been able to pull this sling through. And that stays with that person, presumably for life. I think my least favorite observation of this as a resident, because I did quite a few in residency, was finishing the procedure and then looking back on the person before they were cleaned up and their hips were completely, it was actually, the hips were completely off. So their pelvis was just dynamically completely offset and putting pressure on the bladder. And I was just horrified for the fact that this person had undergone a procedure that now was going to have mesh with risks for erosion, very low success rate, just really unbelievable. And they had a structural dysfunction as significant as that. So, of course, they weren't getting the hold of their pelvic floor to help actually naturally sling the bladder up. And now they had this fibrous synthetic mesh that would also be pulled and tugged and not really seat to hold up the bladder, not to mention all the other complications with bladder slings. Additionally, some people use bladder stimulation units to stimulate the nervous system around. They're usually put in the gluteal muscle, and so they will stimulate the bladder muscle just like a nerve would. It's the foreign body, and it has limited efficacy. And as foreign bodies stay in the body, they can create quite a bit of problems. So one of the other things that's often discussed is weight management. Obviously, what pressure we put in the pelvic floor really matters. Are you basically sitting on your bladder every day? The other thing is smoking cessation. Definitely the bladder is irritated by smoking. In med school, I saw a cystoscope, and it was she's younger than me, like a 40-year-old. She was a 2-pack a dayer. And she already had like 40 pack years, basically. Her bladder was a wreck. I never smoked then. I don't smoke now. But when I saw that bladder and cystoscopy, I was like, I would never smoke if I did smoke. So if you're having bladder irritation and you're smoking, or someone around you smoking, or you have a house that smells like smoke, it's not just if you're smoking. If you're sitting next to someone smoking all the time, you're getting smoke in, and that can also be a bladder irritant. I want to talk about a few holistic treatment options that I think are really paramount. First of all, when we look at exercise, a lot of people are hesitant to do this because of the tone of their bladder. And so I have approach with the rebounder. So this is graphic, I apologize, but you want to lay all the towels down, and you recognize that when you get on the rebounder and you start, you're going to lose your urine because you're introducing pressure into the system when you're using like a mini trampoline in your house or a rebounder. You don't have to do it for very long, maybe 30, 45 seconds. You want to have towels on every surface because you're going to lose urine. And then you're going to do it again, and you're going to lose less urine, like a few days later, less urine. Because when the pelvic floor slings you up, which is what the pelvic floor does, then the bladder has a lot of integrity. And for people who have a little bit of incontinence with overactive bladder, this is a remarkable therapeutic. You do it at home, bounce on a rebounder, clean up the mess, do it again. A few days later, whatever, you're building your pelvic floor, you're supporting the bladder. Critical. Now, next step with that is pelvic floor physical therapy, which is incredible. I really am a huge advocate for pelvic floor physical therapy. If you have a bladder problem, please get pelvic floor physical therapy. It is impressive how much improvement there is. Now, I have definitely worked with people who have failed pelvic floor physical therapy. I say that because that's the term, but it's really awful because it blames the patient. But pelvic floor PT they're really great people who do pelvic floor PT. They're really compassionate. It is invasive, so it can be uncomfortable and awkward. I don't love that part, but it's very effective. And I'd much rather see that than someone sliding right into a sling. And a lot of people don't even have the conversation of pelvic floor PT, and then they go into surgeries, bladder stimulations, medications when it's a structural issue. And that's really important. When we look at things holistically, we want to talk about regaining health for the bladder and the pelvic floor. One of the things that I really am impressed with, and I offer in the office for patients, is vaginal platelet-rich plasma injections. So this is your own blood. We spin it down. We take the gold or the yellow, the serum, with the platelets in it, and inject it for tissue rejuvenation. A lot of times the bladder and the pelvic floor, the urethra area, these are all very, very tired tissues causing a lot of pain. And so tissue rejuvenation helps recuperate in a very accelerated way. And so usually when I do this procedure, I see improvement in the procedure or immediately thereafter. And the patient sees it too. And they really feel a lot more pelvic floor improvement almost immediately. Now, usually I say it takes about 2 weeks. But being a gynecologist and also an osteopathic manipulation specialist, there's definitely ways to do this procedure with a lot more finesse. But in any case, I think this procedure, if it's available in your community, is well worth it. Another thing we use in the office, which is fantastic because it helps rejuvenate the tissue a little bit, much less than PRP, but it's also really good as an anti-infectious treatment, and it oxygenates the muscle. So if the muscle's irritated, if you give it oxygen through bladder ozone therapy, it can be very, very supportive. I'm going to wrap up with a few nutrition support suggestions. There are women probiotics, paramount. Daily, 2 a day if you have any UTI, just get that on board. The other thing, cranberry juice or cranberries or cranberry extract. We put it in our UT Forte. Definitely evidence in the literature to say that cranberry juice prevents urinary tract infections. It therefore prevents bladder aggravation. Now, the literature says about prevention, but not treatment. But if you believe that prevention is the treatment, or if you can prevent it from getting worse, you're actually also treating it. So I won't argue with that nuance in the literature that cranberries that are a juice that's unfiltered and has no sugar, so it's like taking a shot, but when you do it, it's a powerful astringent, and the bladder is very responsive to that. And those are the main things that I want to say. You can do a lot for your bladder, for yourself. And remember, you have to maintain this organ for quality of life metrics and also to maintain independence. If you have any questions, we're coming out soon with, I call it getting square with what's going on down there. So this is an online course I've wanted to offer for a long time. And if you're interested in that, DM us, let us know, or look out for it because I really hope it's coming soon. And I would love your feedback. Thank you so much.